A very good evening to one and all. At the outset, I'd like to put a disclaimer that I am a radiation oncologist and I'm debating on behalf of a medical oncologist for chemotherapy in this topic of local recurrence in a low-risk early CA prostate post-surgery, recurrence with high-risk features but N0 and M0. Now, chemotherapy in prostate cancer has been well established in the metastatic setting, whereas in the non-metastatic high-risk subgroup, it's controversial. Before going into the presentation, we should understand that the cancer-specific survival is poor in high-risk patients, especially in high-risk patients. So why even think of chemo when this is it's like a losing topic when we have a standard of care as radiation and ADT? Why should we even think about chemo in this subset? Because of the heterogeneous natural history of prostate cancer and also to avoid undertreatment of aggressive disease. Now, localized prostate cancer can sometimes be a systemic disease. Some high-risk features which we should be very careful about are high Gleason score and time from primary therapy to PSA recurrence of less than 3 years, a PSA velocity of more than 0.75 per year, and a short PSA doubling time of less than 6 months. With these high-risk features, we should probably, think that this patient might harbor micrometastasis. So the hypothesis is that in oncology, when there is a minor overall survival benefit in metastatic disease, it usually translates into a higher benefit in localized disease, as we have seen in breast and colorectal cancer, where a survival benefit in metastatic disease has translated to a survival benefit in the adjuvant setting. So why not consider the same in prostate cancer? So this was addressed by the RTOG 0512, where to the standard of care of radiation and ADT in high-risk patients, an addition of chemotherapy in the form of 6 cycles of docetaxel was studied and analyzed for the primary endpoint of overall survival with a fairly decent sample size of 600 for a median follow-up of around 6 years. They found that addition of docetaxel to the standard of care improved the overall survival by about 4% and also the disease-free survival from 66 to 73%. Also, they found that there was a reduction in the distant metastasis rate from 14 to 9%, all statistically significant. So they concluded that docetaxel improved OS, DFS and DM rates in high-risk localized prostate cancer, but then we need longer follow-up to use it routinely in the adjuvant setting. Another trial, the G12, which is the French group, studied and compared androgen deprivation therapy versus in addition with docetaxel and estromestin. And all of those patients also received radiation therapy. When they were followed up for around 9 years, for progression-free survival, they found that docetaxel-based chemotherapy improves relapse-free survival in patients with high-risk prostate cancer, non-metastatic, localized prostate cancer. Now, we all know very well about the Stampede trial, and that the Stampede trial has clearly established the role of docetaxel in the metastatic prostate cancer setting, where 6 cycles of docetaxel with ADT results in a significant overall survival benefit in the metastatic setting. When we see the study design, the standard of care was compared with zoledronic acid, docetaxel, or a combination of both for an endpoint of overall survival. Notably, the inclusion criteria had not only metastatic disease, but also non-metastatic node-positive disease or those with high-risk features. They also included patients who have relapsed after radical prostatectomy or radiotherapy as primary therapy, which is our question of discussion today. And they've also analyzed these patients as a subset. And apart from overall survival, as a secondary outcome measure, they also analyzed failure-free survival, which was defined as PSA, local, lymph node failure, death, or distant metastasis. Now, in this Stampede, around 39% of the patients were non-metastatic, of which 24% were N0, M0, which is the question of discussion today. And RT was initially optional, but then it was mandated after 2011 in N0, M0 patients. Now, when we look at the data from Stampede, especially in this cohort of M0 disease, addition of docetaxel improved significantly the failure-free survival, both in the metastatic and non-metastatic subset, whereas it did not result in overall survival benefit in the non-metastatic subset. So the it was concluded that docetaxel is probably suitable in metastatic disease, but not in non-metastatic disease, and it can be considered in a selected few high-risk patients because of the FFS benefit. But what we should understand is that Stampede had 39% of M0 disease, which was also a heterogeneous group of N plus biochemical recurrent patients and high risk locally recurrent patients. So it had limited power for a subgroup analysis. The statistical power for the primary overall survival was the entire patient population, including all these patients, whereas restricting docetaxel only to the metastatic group is like emphasizing negative subgroup analysis in overall positive trial. Whereas positive subgroup analysis in overall negative trials are usually de-emphasized. So why should we not give the benefit of doubt in Stampede? Now, the most recent one, which was published in December 2021, analyzed the addition of Aberetron and Prednisolon in high-risk non-metastatic prostate cancer, which is also a meta-analysis from the the same Stampede platform protocol of 2 randomized phase 3 trials. They address the question of addition of Aberetron acetate with or without enzalutamide with the standard of care for the primary endpoint of metastasis-free survival. The inclusion criteria not only included N- with high-risk features, but also those who are relapsing with high-risk features, the same case for discussion today. So they found that with a median age of 68 and median follow-up of 72 months, they found that the metastasis-free survival was significantly better with the addition of Aberetron to the standard of care, either with or without enzalutamide, with a hazard ratio as good as 0.5. And also they found that the overall survival was significantly better when Aberetron was added to the standard of care in this subset of patients. So this is, to our knowledge, the first report of a systemic treatment when added to ADT improves metastatic free survival and overall survival in prostate cancer who are non-metastatic and high risk. So in fact, they have said that this should be considered a new standard treatment for this particular population. Now, how do we compare Aberetron with docetaxel? Another analysis from the Stampede group compared head-on the data between Aberetron and docetaxel and found that there is a strong evidence favoring Aberetron, especially in biochemically driven outcome measures like failure-free survival or progression-free survival. But then there was no significant difference between the two for more clinically driven outcome measures like bone complications, cancer-specific mortality, or overall survival. So the key is in selecting those patients who have life-limiting prostate cancer, but they are non-metastatic, which is again a heterogeneous group. And non-metastatic, the word itself is a misnomer because PSA rise after radical prostatectomy could mean a residual disease in the prostatic fossa, micrometastasis, or both. So probably the utility of PSA doubling time should guide us in this particular subset, because patients with PSA DT less than 10 months have a very high risk of bone metastasis and death. So probably that should be used as an index. To conclude, in this subset of non-metastatic disease, we have various options. Like we don't even treat some patients. We treat some patients with local therapy alone, but we might also look at some patients who might be harboring a microscopic metastasis. So early use of chemotherapy in a non-metastatic N0M0, we should probably consider in those patients who have extreme high risk of microscopic metastasis, PSA doubling time of less than 3 months, and healthy patients who have long duration of survival, and youngsters. I thank the organizing team for giving me this opportunity. I conclude by projecting myself like Karna. Myself being a radiation oncologist, I was pushed to the Kaurava side, and I was asked to present and debate against my own kith and kin. And I thought I have done some justice to this topic that was given to me. Thank you so much.
Thank you, Dr. Satish. You completed in 8.5 minutes. Let's move to the next speaker, Dr. Anand.
Good evening, everyone. Am I audible?
Yes, you're audible.
Yeah. Are you able to see the screen?
Yes, the screen is visible.
Okay.
You can start.
Yeah. Thank you. I thank the organizers for this debate. Let me go directly into it. Outside, I thank Dr. Satish for agreeing that RT is the standard of care in this setting. So at least it saves me half of my talk, not to try to prove that RT is indicated in this setting. So I will go directly to, one second. Yeah. So this is the topic that has been given. It's a low risk early prostate cancer. This is a patient who has undergone radical prostatectomy, and he has got a local recurrence with some high risk features, but it is N0 and M0. And I'm going to talk about why radiation should be the standard of care in these patients. The underlying fact we have to remember is, so these are all old men. They have undergone a radical surgery, and most of them are with some comorbidities probably. And our goal in this patient should be to give a good disease control and a quality of life. Both are important, with as less treatment as possible. So this is the definition of all the 3 points: the low risk cancer, the local recurrence, and high risk feature. All the three of these first 3 points is a low risk prostate cancer. The recurrence can be because of, that's what we are going to concentrate on. The recurrence can be because of 2 consecutive rising PSA after radical prostatectomy, because ideally the PSA should be non-detectable. Or if there is a PSA persistence after radical prostatectomy more than 0.1 nanogram per ml, then the cutoff is actually different across various trials, but this is the most accepted one. Or we find a local recurrence by imaging. I think the third point will be the least common of these 3, because it's a low risk prostate cancer gentleman who has been operated upon. Now, how do we define a local recurrence? The gallium-68 PSMA has been the most studied modality. We saw in the last panel discussion as well. So it has a 75% sensitivity and 99% specificity, but the positivity rate also depends upon the PSA level at which we image. So if we are imaging at a PSA level less than 0.2, there is only a 35% positivity, and it jumps to 95% if your PSA level is more than 2 nanogram. And what is the use of multi-parametric MRI? We don't know the utility in PSA levels less than 1, but apparently it has got a better sensitivity to detect a local recurrence than a PSMA PET. The important point is detection of a local recurrence by imaging is not a prerequisite to start salvage RT. Most important point. Why do I say that? Because your metastasis, your biochemical recurrence, and the mortality all jumps up if your PSA goes up before starting RT. The metastasis incidence is around 9%, just inside the graph, 9% if your pre-salvage radiotherapy PSA is less than 0.2 versus 37% if your pre-salvage PSA is more than nanogram. So we have to start radiation early. So no question about it. So what is the outcomes of salvage RT? We have 3 trials which has given us outcomes, all published in 2020. Raves from the New Zealand group, Radicals from the UK, and Get2Keep from France. This is basically a randomized trial which had an adjuvant RT arm and also a salvage RT arm. Once the PSA rises, they will start RT. The salvage RT arm had around 1,000 patients across all the 3 trials. And the salvage radiotherapy arm showed a 5-year biochemical progression-free survival of 90%. Remember, these are all patients who progressed after a prostatectomy. And see the toxicity profile. The most, the concern, we are more concerned about the GI toxicity after radiation. The grade 2 or more GI toxicity was less than 10% across all the 3 trials. And most important point again, the pre-salvage radiotherapy PSA level was 0.2 in all these 3 trials. So this is just a summary. I will not go into the details of it. So we can say that the biochemical progression-free survival was 90% with a good survival and a good control rate and a good toxicity profile. So this is the European Association of Urology guidelines. Strong recommendation to offer IMRT with image guidance if the PSA rises. So no question here that radiation has to be offered or is the standard of care in these patients. So I will just go a step ahead because the debate was with chemotherapy. I would say even don't give ADT for these patients. So what is the benefit of adding even an ADT to the salvage radiation? We have 2 trials that address this question. One was an RTOG trial and another is a AFU16 trial. Both of them gave salvage radiation with or without a systemic ADT agent. The RTOG used 2 years bicalutamide and Get2Keep used 6 months of GnRH analog. Both of them had their primary outcome endpoint was progression-free survival. Both of them showed a betterment in overall survival or a metastasis-free survival. If you look at the graph of Get2Keep trial, The left panel is the progression-free survival. The standard arm is radiotherapy alone. Again, no debate whether radiotherapy has to be given or not. The experimental arm, the curves are really dividing in the PFS. But if you see the metastasis-free survival, though it is statistically significant, the curves seem to be hugging each other. If we dive deep into these studies, there are lots of fallacies. First, the choice of a primary endpoint. What do we actually want in this group of patients? Should we start ADT at the time of salvage RT, or should we start ADT once they progress? This is actually the answer we want from these two trials. But if your primary endpoint is progression-free survival, you will not answer this burning question. So it's the choice of a primary endpoint itself was a problem. And see the timing of RT in these two trials. The median PSA was 0.3 in GETAC and 0.6 in RTOG, which was way higher than the Raves, Radicals and GETAC 16 trial, which was 0.2. And the GETAC trial used the old RT technique, lesser RT dose, it was less than 66 gray, and bicalutamide as a choice of ADT, which I don't think anybody of us will be using anymore. And in a subgroup analysis, it showed that the OS improvement was seen only in those patients who had a pre-salvage RT PSA of more than 0.6. If you start salvage RT before, less than 0.2 or 0.6, the OS improvement was not seen. And what did we pay for that? There was an increase in other cause mortality. This was twice higher than those patients who did not receive ADT. And there was around 3.5 times odds of getting a grade 3 to 5 cardiac and neurological toxicity. So again, the EAU says that, you have a weak recommendation to offer hormonal therapy, even hormonal therapy in these patients with SRT. So again, I'm reiterating the fact, these are old men, post-radical surgery, most of them with comorbidities. So the emphasis should again be on close monitoring these patients, ultrasensitive PSA testing, and start radiation at the earliest signs of biochemical progression. Don't wait for imaging. Don't wait for pathological confirmation. The control rates are very good. A 5-year biochemical progression-free survival of 90% with very less toxicity of less than 10% grade 2 or more toxicity, combining all the 3 trials. There has been a meta-analysis of all the 3 trials, which was a pre-planned meta-analysis, artistic meta-analysis, which was published again in 2020. So multiple treatments have to be avoided in this population, leave alone chemotherapy, even ADT, unless we have a very sufficient proof that adding a systemic therapy during salvage RT is beneficial than adding a systemic therapy at progression. So the only answer we will get is from Radicals trial, which has a second randomization. So they randomized the salvage RT group into no ADT versus 6 versus 24 months of ADT. But until we get those results, I think we have to concentrate on picking up these patients early, treating with radiation early, rather than adding a systemic therapy, a chemotherapy, or a ADT, and adding to the toxicity. Thank you for the time.